What's up, y'all? I'm back. Dr. James Hall. I am a nephrologist. I've been practicing for about 20 years, and we're talking about a specific case today. I will jump right in. This is an 18-year-old black gentleman. No past medical history. He's actually a college football quarterback. He presented to an outside emergency room with acute kidney injury, acute renal failure, and his serum creatinine was 1.43 milligrams per deciliter, and his BUN was 7, albumin was 2.0, and at that time his family, we know them personally, his family called me and they wanted to try to get him in to see me with those labs. So the other thing I want to note is he had a urinalysis that showed 1 plus blood, 3 plus protein. When I see labs like this, most times when it's summertime, I'm automatically thinking dehydration, because a young black male, why would his creatinine be 1.43? And the other thing I'm thinking is, when I say albumin of 2.0, why should a young, healthy athlete have a low albumin? He's not malnourished, trust me. He's not fat, but he's not malnourished. I mean, he's pretty solid. He's a college quarterback. So when you as a primary provider see a low albumin, when you check labs in your clinic, you need to think, yes, malnutrition is an obvious cause of low albumin, but in my state, Mississippi, we rarely get low malnourished people come in my clinic. Less than 0.5% of the patients we see are malnourished. So you got to think proteinuria. This patient is losing albumin in the urine. That's proteinuria. That's what you should think as a provider when you see a low albumin when you check a liver panel. Also, liver disease. Cirrhosis can cause a low albumin. One of the main, the top 3 liver tests that give you liver functionality are albumin, bilirubin, and PT and PTT. So a lot of people think it's the liver function test, but those tests are not very sensitive or specific. A lot of things can make those go up. So medications can do that, sickness can do that, low blood pressure can do that. So I don't rely on the AST and ALT quite as much as I rely on the albumin, bilirubin, and the PT and PTT to actually look at how well my liver is doing. So that's a tidbit for you. That one's free. We're not talking about liver, because I love you with all my kidney, not my liver. So you see a low albumin, your thought process, proteinuria. Then you should look at a urinalysis. This guy had 1 plus blood and 3 plus protein. That tells me, yes, there's blood, yes, there's protein, but it doesn't tell you how much. That's what you really want to know. How much protein is this patient actually spilling in their urine? That's where your urine protein to creatinine ratio comes into play. You take a spot urine sample, take the urine protein and the urine creatinine, divide them, and that gives you the amount in grams of protein that the patient's spilling in a 24-hour period. That's gold. That's valuable. That information to us nephrologists, man, that's like to us. Because once we know how much protein a person's spilling, we kind of have a really good formula for what's next. We have a good indicator of what to do next. If it's 500 milligrams, that's low-grade proteinuria. It's not that much to worry about. It's worrisome, because proteinuria is the first sign of kidney damage. So it is worrisome. If it's 1,000, 1,500 milligrams, 2,000 milligrams, okay, now we're talking serious proteinuria. We need to figure out what's going on. Does this patient have untreated diabetes, untreated hypertension? Does this patient have lupus nephritis that's undiagnosed, which we see a lot in young black females? Does this patient have ApoL1 mediated kidney disease that's undiagnosed? FSGS. Is this patient taking NSAIDs that's causing proteinuria or causing membranous nephropathy or allergic interstitial nephritis? So the amount of protein really can help you out because some conditions cause a lot more proteinuria than others. And so that's the kind of things we look for in clinic. When you see low-grade proteinuria, usually it's like maybe a little blood pressure, or it could be transient, heavy exercise, sometimes orthostatic proteinuria, sometimes an acute illness could cause proteinuria. But what we want to do is try to quickly identify the culprit and then treat that. So back to my case report. Creatinine 1.43, BUN 7, albumin 2.0, 1 plus blood on his UA 3 plus protein. So we're trying to figure out what's going on with this guy. We asked him to drink a lot of water. We asked him to come back to our clinic so we can try to get an idea of what actually happened, what caused his renal function to be low, his creatinine to be high. So I want you to kind of stay tuned. This is part 1. I want you to stay tuned for part 2 because we'll be talking about what happened with this patient, what did we do, what's our next step. We may eventually end up biopsying this guy because of that low albumin makes me think he has significant proteinuria and we need to do something about it. Incidentally, his blood pressure was normal, so that's a good thing. Typically, when you have nephrotic syndrome, you have greater than 3.5 grams of protein in the urine, you have a low albumin, and you have a really high blood pressure. So we don't have a urine protein to creatinine ratio yet, but we'll be getting it, and we'll be letting you guys know what his urine protein creatinine ratio is. And then we can kind of, fully elucidate the etiology of his renal issues, and then treat it if there's a treatment available for what he has. My suspicion is that he could have ApoL1 mediated kidney disease, which causes an FSGS type scarring on the kidney. That's very common in some of your black ethnicities. So I hope not, because he's playing football, he's young, but we have to do our diligence to get to the bottom of this guy's renal dysfunction, his low albumin, and his proteinuria and hematuria. Incidentally, when you see a patient with hematuria and proteinuria, that's an indication to biopsy a patient. Acute kidney injury in the setting of proteinuria, hematuria, low albumin, that's an indication to biopsy a patient like this. On the front end, and not kick the can down the road and wait till something bad happens and then try to biopsy. I want to biopsy him now, figure out what's going on. We also plan to do a genetic testing on this patient to figure out what his genetic problems are, or genetic issues, genetic hybrids, or any type of genetic issue that we can diagnose, and that will also coincide with the biopsy to help us really get a good plan on treatment. So I appreciate you guys tuning in. Check out our free webinar below. We have an online course that has 7 modules. You can check that out too. Please see us in the next video and stay tuned for part 2 of this 18-year-old black male with acute kidney injury. Thank you. Goodbye.